All right. I think we will get started. So thank you everyone and welcome to our webinar Lunch and Learn on preventing HPV. My name is Mary Lizakowski, and I'm a Coalition Health Director with the Foundation for a Healthy North Dakota. It is a newly established nonprofit in North Dakota with a small team. Our mission is to promote health and wellness by working at the community level across North Dakota. We are building a statewide coalition to allow local communities to collaborate and work together on common initiatives. And by joining the coalition, members will be the first to know about educational opportunities such as this, the latest on relevant public health information, legislative updates, and access to digital advocacy resources and toolkits. So some housekeeping things to let you know about. Webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the Q&A box. Our team will be monitoring questions that may come in. We will be recording this presentation and we'll leave time at the end to address any questions you may have, along with the questions that came in during registration. And after the presentation, a link to the recording will be sent out along with an evaluation survey to complete. It is my pleasure to introduce our presenters today. Dr. Jennifer Smith is a professor in the Department of Epidemiology at the University of North Carolina and has conducted research over the past 20 years with a focus on epidemiological studies of infections and cancer. Her research focuses on HPV infection and cervical cancer prevention worldwide via screening and prophylactic vaccines among women with limited access to care. Dr. Smith's work expands globally with a focus on North Carolina, Sub-Saharan Africa, and China. She earned a doctorate degree from the Johns Hopkins Bloomberg School of Public Health. Dr. Smith is the director of Cervical Cancer Free Coalition and has published over 300 articles in international peer-reviewed journals, of which over 260 are related to HPV infection and HPV-associated diseases in the areas that include cervical, anal, vaginal, vulvar, and penile cancers. She is a mentor to the Cancer Control Education Program and for the Fogarty International Clinical Research Scholar Program and associate editor of Sexually Transmitted Infections and on the editorial board of Sexually Transmitted Diseases. So welcome, Dr. Smith. And our next presenter is Tamika Felder. She is a cancer survivor, award-winning women's health advocate, and chief visionary at Cervivor, a nonprofit dedicated to cervical cancer advocacy and support. Tamika also has a mission to eradicate cancer and shine a spotlight on the patient voice in healthcare. Named a cancer rebel by Newsweek, Tamika is a highly sought-after speaker on cervical cancer advocacy, cancer prevention, HPV education, and living life with purpose. She shared her story on presidential panels convened by the White House, trained thousands of ambassadors using her signature patient advocacy framework, and traveled internationally to share her experiences with women around the world. Tamika currently serves on the steering committee of the National HPV Vaccination Roundtable. As a member of the Family Reach Cancer Equity Initiative National Strategic Council, she is regularly tapped by leading organizations and Fortune 500 companies around the globe to share her story and expertise. An award-winning television producer and host, Tamika is a captivating personality and an engaging and talented storyteller. Her work has led to her being featured in Bravo's Real Housewives of Beverly Hills franchise and a profile feature in the award-winning documentary, Someone You Love, the HPV Epidemic. So nice to have you both here, and I will turn it over to Dr. Smith to share her presentation.
Wonderful. Thank you very much, Mary. I really appreciate this invitation to speak with you today, and also for allowing me to speak before Tamika. So I really appreciate that as well, because it's hard to follow her act. So thank you very much. I wanted just to open up with that my presentation today will be on the where we are right now with HPV vaccination in the United States and the story of the tortoise and the hare. As has been said, I'm here from the University of North Carolina in Chapel Hill at the Gilling School of Global Public Health, and really looking forward to a lively chat session afterwards. So I'm going to try to stick to time. I have until 1:40, I've been told. So I'm not sure what's happening, but I can't move my slides forward for some reason. Maybe I will, maybe Mary, if you wanted to maybe pull up this, I'll stop sharing and share again, perhaps. Otherwise, I might have to have you pull up my slides and share them, but let's see.
Sure. Would you like me to do that?
That would be great, because right now I'm not able to move my slides forward.
Oh,
you get my slide without slides, but it might not be as lively as with my slides.
Okay, 1 second, let me pull them up.
Perfect, thank you. Well, basically, I think today I'm going to talk a little bit about what is considered a glass half full, in that we have roughly 60% coverage of vaccine among girls in the US, and the rates among girls and boys are continually going up. I will also say that from a large perspective, as we kind of think about HPV vaccination in the US, that our rates are consistently lower in some of the rural areas than some of the urban areas. And so that's actually quite a big issue in the US, as we're trying to think about how to increase vaccine coverage, trying to ensure that there's equity and coverage across all areas. And so thank you, Mary, for helping. And hopefully your slides will progress, and the next slide, hopefully. So thank you. So HPV-associated cervical cancer incidence rates by state in the United States. These are the most recent data that we have from SEER, and it's 215 to 219. As you can see on this slide, we see a consistent north-south divide, and with some of the states in the darker blue colors have higher incidence rates than states in the lighter blue, or even like partial white incidence rates. So you can see here much higher rates in New Mexico, Texas, and you can see the states in Florida having some of the highest rates. And this actually also maps out pretty well with states who may not have opted for the ACA increased coverage in terms of provision of access to insurance updates. So then going on to the next slide, we actually have roughly 11,000 cases and 4,000 deaths. And this is 11,000 cases and 4,000 deaths too many, in my opinion. So I give many lectures in the world where we stamp on the table and say enough is enough. We should really be eliminating cervical cancer from the states. And that's really the WHO global program to talk about elimination. So next slide, Mary. So looking at, what are the cancers that are caused by HPV infection? I think we all know that HPV causes cervical cancer, and you can see here that that's the most common cause of HPV-associated cancer in the US. But I think it's important to know that a little over half of HPV-associated cancers in the US among females are non-cervical cancer. These include vulvar cancer, oropharyngeal cancer, the oral pharynx, and anal cancer, as well as a smaller proportion of vaginal cancer cases. And I think it's important for when we're thinking about vaccination programs, we can screen successfully for cervical cancer, but we don't have methods to screen women in reproductive age for vulvar, vaginal, and anal cancers at the moment. And we don't have any way of clearly screening for oral cancer, because we don't have very clearly delineated precancerous lesions to screen for. And then looking at the HPV-associated cancers in men, I will also say that the overall numbers of cases that affect women and men in the US are roughly on par, 26,000 in women and around 21,000 in men. And most of the HPV-associated cancers in men in the US are oral pharyngeal cancers, followed by a smaller proportion of anal and penile cancers. Next slide. So what does it look when you look at HPV-associated cancers by race and ethnicity? If you look at all of the races combined, we have roughly 7.3 per 100,000 estimates of incidence of these HPV-associated cancers, and they do appear to be higher in Blacks as well as in Hispanic Americans as compared to whites and the other ethnic racial groups. Next slide. So what are the trends that we know of HPV-associated cancers in the US? And these are a little earlier data from 2001 to 2017. We've seen actually some very positive things in that cervical cancer rates have been consistently declining. On the other hand, we see that, that there's really a nearly fivefold higher incidence of oropharyngeal cancer as compared to women and men as compared to women. And more than 80% of men with HPV-associated cancers were diagnosed with oropharyngeal cancers. And we have had some recent notations and meetings of increasing incidence of these HPV-associated oropharyngeal cancers. The anal rectal cancer group incidence is also increased in all racial and ethnic groups, and the largest increase that we've seen is among Black men. Vulvar cancer cancer rates have slightly rose, with the largest increase among women aged 60 to 64 years of age, and penile cancer rates have remained stable and relatively low. Next slide. So if you remember anything of my talk, I hope that you remember this beautiful HPV virus-like particle. And this is what led to the HPV vaccine revolution in terms of prevention. So these prophylactic vaccines, preventative vaccines, are based on this recombinant L1 capsid proteins that form these quote unquote virus-like particles, VLPs. And I'm not sure, since can you see my my arrow here, Mary, or because you're forwarding the slides? No. Okay, so the virus particles, you see the one in the very center of the image, they actually formulate as pentamers. And these are non-infectious, non-oncogenic. Basically, they're empty capsid particles that mimic the actual formation of a true HPV infection, live infection. But however, unlike live natural infections, when we have a natural infection with HPV, we don't mount very high immune responses to HPV. On the other hand, these virus-like particles that are, again, empty capsid particles, they look exactly like the conformation of a natural HPV infection. On the other hand, they actually produce very high levels of neutralizing antibody titers as compared to natural infection. So these vaccines that mimic the conformation of the HPV infection actually are leading to whopping antibody titers. These antibody titers are literally 100 times, higher than that you see in the natural infection. So if you're kind of thinking about the story of viruses and how viruses work, we know that HPV is able to really trick the immune system in that the natural infections don't cause much antibody response. They hide from the immune system. HPV is able to survive because it hides from the immune system, and the immune system doesn't detect it very well. That's why we, unlike HIV, for example, we are not able to rely on serology tests to determine who has been infected and who has not, because HPV hides out from the immune system and doesn't lead to much immunological response in a natural infection. And this is very different than what you see with the vaccines. After even one dose of a vaccine, you see whopping antibody titers, very much greater antibody titers following vaccination than you see with a natural infection. Thank you, Mary. Next. So we actually have had in the US market 3 vaccines over time. The bivalent vaccine from GSK was first introduced on the market with prevention against 16 and 18, which are the 2 most common types in invasive cervical cancer. And they account for roughly 70% of invasive cervical cancer cases. Then we had Merck, who came on the market with a quadrivalent vaccine, and this included the 16-18 for 70% prevention. Maybe move the next slide, Mary. Next slide. that included also protection against virus types for HPV 6 and 11. And these prevent roughly 90% of genital wart disease endpoints. And then the third generation vaccine was the Merck non-valent vaccine, which is really what we have on the US market now, which actually also provides protection against HPV types 31, 33, 45, 52, and 58. And these protect an additional 15% of invasive cancers. I wanted to be really clear. HPV is really a messy virus. There's a lot of virus types. There's roughly actually 14 types, 13 to 14 types that cause invasive cancer. These vaccines were made to prevent invasive cancer. There are other high-risk types that can cause high-grade lesions or even low-grade lesions. And so although the vaccine works very, very well against the types that cause invasive cancer, it doesn't remove the absolute risk that your child or in adulthood actually acquires some low or high grade lesions. Again, the types that are used in the vaccine are to prevent invasive cancer. And we can talk more about that if it's helpful. Next slide. Hopefully it'll progress on. Okay, perfect. So here's where we are with coverage of adolescents age 13 to 17. We actually promote vaccination in earlier ages before little Jenny Sue has her third date, for example, in order to ensure that we have the most effective approach. As young girls become sexually active, young boys, you'll have exposures, and that will actually then, if they're exposed to certain virus types in the vaccine, for example, HPV type 16, then they will have less protection against that type. So you really want to try to vaccine young girls and boys before they become sexually active. And that's why we have this younger age group that we're looking at here. And the target for universal vaccination is actually up to age 14 with discretion down to age 9. So 9 to 14 is really the target group. This coverage range is a little higher than what we would use for our target program. But just to show you some of the data that came out from MMWR, I think that's really important, and we had a lot of discussions about this during there's a series at the President's Cancer Panel. We discussed the HPV vaccine coverage and differential. So here we see that Tdap and meningococcal vaccine in the red and blue have very high coverage rates on the order of 90%. This is very, very high as compared to looking at the orange line here, which is a 1 dose of HPV vaccination. So you see that young kids are going into their doctor's office. They are getting Tdap and meningococcal vaccinations in this adolescent age range, but they're not getting HPV. And so why is that? And we'll talk a little bit more about some of the strategies about bringing providers on, because they're the ones who have the most likely possibility of actually increasing vaccination coverage by their recommendation to their patients. There were some also recent recommendations in 2016 by the ACIP. This is the national group that actually does all of the national recommendations around HPV vaccination, or all childhood and adult vaccinations in the US, where they actually had this recommendation to ensure being up to date with vaccination. And so you can see here, as they're focusing on getting kids up to date, meaning getting them vaccination early according to schedule and not late in the later catch-up population up to age 26. The goal was to try to really move vaccination into the younger 11 to 14 or 9 to 14 age group. And so I think that's actually really been, you can see here that there has been, with that effort of trying to focus providers on, are their patients up to date for HPV vaccination, that has also increased since the 2016 recommendation. Next slide, please. So where are we with like national? I started out at the beginning talking a little bit about that, roughly in the US, I think it's 32 states actually have over 62% coverage of vaccination in the US. And you can see some states that are doing really well. I think Rhode Island is one of them, and some of the other states in green, California, the other states that are falling somewhat more behind, and the ones in the white and the pink. So I think there are variations across states, and that has to do, as I said earlier, with policies related to vaccine coverage, particularly among uninsured or underinsured populations in their state. And I think we have a lot more to do to try to really promote vaccine uptake. Next slide, please. So again, is what I said earlier, it's really a glass half empty and a glass half full, depending how you look on it. We have done a very good job with increasing provider education in the US, trying to really bring providers on board. And I'll talk a little bit more about that. But again, we have a long ways to go if we want to really get up to our potential of over 93% coverage among our adolescent population, which I think really could save lives. And particularly, as I said earlier, for those cancers that we don't screen, and we don't screen for oral cancer, we don't screen for penile cancer, we don't screen for vaginal vulvar cancers, and trying to really ensure vaccination also for those cancers that we can't screen for is critical, as we also have other benefits of vaccination in terms of reducing the burden of low and high grade lesions among females. Would actually reduce, again, colposcopy and follow-up screening abnormalities, and that's also a big benefit of vaccination. Next slide. So what is the dosing regimen right now for HPV vaccination schedules? Right now, we are at 2 doses for young adolescents, 9 to 14 years of age, except people with immunocompromised conditions. So 9 to 14, 2 doses, and these are at your baseline first vaccine, then followed by the second vaccine between 6 and 12 months. And then for those who are 15 to 26 in this kind of catch-up group, there is still a recommendation of 3 vaccines at 0, 1 to 2 months, with a third dose at 6 months. And so there's a lot of discussion globally around the potential for 1-dose vaccination. And it'll be very interesting as more and more data accumulates on 1-dose vaccine, whether we'll be also moving to a 1-dose vaccine schedule. Right now, the WHO is recommending a 1 dose in these younger girls, 9 to 14 globally, and 2 doses in the older age group, as well as increased doses for patients who are HIV seropositive. So it'll be interesting to see how this plays out in the ACIP. There's currently no discussions, there are no planned meetings on the board for the ACIP, but it'll be interesting to see how the 1-dose discussion moves forward. Next slide, please, Mary. So you can imagine from a patient perspective that having fewer doses would equivalent to less pain, less visits. And so I think that's really been, I think, one of the real impetus for really trying to educate parents. Hey, if your daughter or son is less than 15, that means only 2 doses versus 3 doses. So I think that's actually also been, I think, really, really beneficial that the data does support having fewer doses in younger age, largely because the immune response at younger ages seems to be higher than that. It's been shown to be higher than that in older and relatively older ages. And we wrote some piece on this in, a few years back. But in essence, I think that's actually quite beneficial as you think about rollout. Next slide. So I think with every talk that I ever give on HPV vaccine, it's really important that I spend quite a lot of time talking about vaccine safety, because that's obviously the big question that comes in from audiences. And I think that as you're looking at vaccine safety, you are looking at, when you're making recommendations, you need to take into account the efficacy of the vaccine, which is the ability of the vaccine to work as intended to prevent illness, as well as the risks associated, probability of increased adverse events that harm individuals or populations. Next. So there's a lot of efforts obviously involved in monitoring HPV vaccine safety in the US. And this is not just for HPV vaccination, but for all vaccines. FDA and the CDC closely monitor vaccine safety after the public begins using a vaccine. And there's this vaccine adverse event reporting system. And this actually allows individuals, anyone, including yourself, can make a report. This includes parents, patients and healthcare providers to report directly in the system. And they also have the vaccine safety link, which is a combination of networks of healthcare providers who actually use information systems to actively monitor vaccine safety following original rollout. Next slide. So there's ongoing safety activities, as I said. There's VAERS, which I just described, which is a spontaneous reporting system, and the vaccine safety data link, which I just also mentioned, that has over 113 million members. And then there's a clinical immunization safety assessment, the CISA project, which has expert collaboration with the CDC and 7 academic centers that actually conducts individual clinical vaccine assessments. So next slide. So in these are also like non-CDC activities, of post-licensure phase 1 commitments from the manufacturers to actually develop vaccine registries in pregnant populations, long-term follow-up in Nordic countries, and then WHO's Global Advisory Committee on Vaccine Safety. And they just came out with the global 1-dose recommendation. And then the Institute of Medicine's report on adverse safety events in vaccines. Next slide. So there's been 7 pre-licensure studies, including more than 15,000 males and females, and the vaccine has been well tolerated. The adverse event profiles are very similar to that of the 4-dose vaccine when you look across stratifications of age, gender, race, and ethnicity. And there's been slightly, there's like local injection site reactions that are expected that you would receive from the 9-dose vaccine. Thank you. Next slide. Vaccine impact. I think this is really important as you're thinking about roll-up of national programs that you look at, how the vaccine has actually, in the end, impacted on early outcomes, which you can measure in a few years of prevalence of infection and genital warts, which can be really quite common prior to vaccination, and see the impact of vaccine on large populations post-vaccination. And then, looking at the mid outcomes, which are years to decades, that look at CIN and precancers as outcomes to look at the impact of the vaccine on that, and late outcomes in decades on HPV-associated cancers. We saw some exciting data that came from Australia. Had one of the most early introduction countries in terms of their introduction of vaccine, and actually have shown some incredible data on the impact of vaccine on all of these outcomes, early, mid, and late outcomes, with very, very positive and not unexpected, but positive impact of vaccine being demonstrated in the large Australian national context, which I think is what we all found very exciting as we see the real impact of the vaccine on the population, which is really the hope that we saw when the vaccine came out, that the vaccine, increasing coverage, increasing burden of HPV-associated diseases, and then decreasing burden on the population for really very severe cancer outcomes. Next slide. So currently, it relates to the discussion we've been having about 1 dose, is that the study suggests that the vaccine protection is long lasting, and there's really no evidence of waning immunity. This mainly means that when someone has these whopping antibody titers I'm talking about, that they stay relatively stable over time. And that actually has been really the vaccine titers after the original vaccination have stayed really very stable over a period of over 12 years. And when you see these vaccine titers really quite stable, then that was one of the reasons why they've started looking more and more into this idea of, can we reduce the number of doses that are required, given the stability of the vaccine titers that were generated after vaccination. And so currently the vaccine titers do, and we just got back I got back this weekend after attending the IPV conference in DC, and you see the slide after slide, stable titers of vaccination with following the doses. And that I think is actually really exciting as we think about potential for fewer doses. Next slide. So as I've said, it's safe, the vaccine's safe, it's effective, and it provides lasting protection. And so I think as we look at like risk-benefit ratios, benefits of vaccination will far outweigh any potential risks. And the safety studies for vaccination for HPV are similar to safety reviews for the meningococcal and Tdap vaccination. It has shown very high population impact against early and mid outcomes in multiple countries, and I said in Australia in terms of late outcomes as well. and it lasts, and they said the vaccine is long lasting, and there's no evidence of waning of protection, meaning the antibody titers are quite stable over time. Next slide, please. So I think this is actually, I think that in the US where we really are, we have, vaccination coverage, as I said, around, 70, 60 to 70%. Some states, as I said, have lower coverage rates and some have higher, but on average, here we are at roughly 70% actual coverage, and we want to really get up to this 93% coverage of young girls and boys by age 13. And so I think there's where we have to really make concerted efforts, and these are programmatic interventions with clinics and clinic staff to really figure out how we can really bridge this gap. Next slide. So what are some of the barriers of why we aren't getting up to the 93% target or even 100% target, if you want to be completely optimistic? We don't have any school-based vaccination programs. And a lot of the countries in Europe that are achieving higher vaccination coverage actually do bring the vaccines out to the adolescents where the adolescents are. And we unfortunately do not bring the vaccine to the schools. And there are some reimbursement issues of doing that. We held a conference in Atlanta years ago discussing opportunities to do this. And there are a lot of potential reimbursement issues of trying to provide vaccine in schools and in pharmacies, which is the last bullet point in the slide. And then because that vaccine is largely provided by in-clinic doctors, and so that adolescents have to go to the clinic to get vaccinated. And there's a rather, we could just simplify, say rather complicated preventive healthcare system, and it's difficult to reimburse if you provide vaccine in these alternate delivery sites. If we want to provide vaccine in schools, there's a lot of obstacles to this, and it's hard to get reimbursed for the vaccine coverage at that particular alternate delivery site, and lots of obstacles to jump to do so. And that also is the same in pharmacies, although I think the pharmacy issue, we're actually providing more and more vaccines in pharmacies to increase access. So what about framing the conversation in terms of how do we move up to the rates that we see and for adolescent vaccine coverage for Tdap and meningococcal vaccines? Next slide. So first of all, I think several years ago, the message originally was HPV, female, cervical cancer prevention. And then they really worked very hard on different campaigns as they were introducing vaccines to boys, because the vaccine came out originally for girls, and then it moved to introduce the vaccine for boys. And so then they really started to change the messages about HPV vaccine is for cancer prevention, meaning it's not just for cervical cancer prevention, but it's for cancer prevention. That's what I was saying earlier. It's about oral cancer and vaginal vulvar cancer and penile cancer prevention, and that we should really be talking to your doctor about getting your 11 to 12-year-old sons and daughters vaccinated against HPV, and stopping HPV, but stopping HPV for cancer prevention, and really building out that as a prevention message. Next slide. So I think one thing that they've seen, and this is a study that was published in 2014, is it may also be that the providers underestimate the value that parents place in vaccinating their children. And you can see here for looking at different providers say, oh yes, the parents really do see the value of vaccinating against meningococcal, hepatitis, pertussis, influenza, maybe less so. But HPV was the biggest difference between the perceived benefit from the provider as compared to the parents themselves. And so I think that is just also kind of educating providers. I think one of the real things that we see as we thinking about HPV, that a lot of the champions of the really trying to promote on a state-by-state level increased vaccination coverage in the population is a gynecological oncologists. They're the ones who actually see those cancers. They're the ones who are operating on the cancers. They're seeing the woman come in with invasive cancer. And these are the champions who are really going out and trying to increase vaccine uptake. The issue is that pediatricians who are, or the family doctors who are actually at the point of care to provide vaccines aren't as familiar with what it looks like on the end when a woman gets an invasive cancer. And so I think that has been a lot of the efforts being made to try to educate those frontline providers of young adolescents, the family doctors, the pediatricians, with the information of what it actually looks like when someone gets an invasive cancer, because they're not actually seeing those invasive cancers within their pediatric populations, because the invasive cancers occur much later. Next slide. So I think sometimes providers are thinking that conversations may be uncomfortable to talk about HPV, and that assuming that parents don't want the vaccine, or that they think that the discussion will take quite a long time. And so therefore, the providers unfortunately discuss HPV vaccine after all the other vaccines, or not at all. So they say, okay, your daughter or your son need meningococcal or Tdap, and then maybe HPV later on or next time. So I think that's been a lot of the work that Noel Brewer, a colleague of ours at UNC, has been focusing on, is just how to put HPV right in the middle. You know, your daughter or son, they need the meningococcal, HPV, and Tdap today. So let's just go and get them vaccinated for all three. Next slide. Next slide. So providers need to make an effective recommendation. That's, I think, really clearly, like, we know that providers' recommendation is the biggest way that we can actually ensure changing parents' minds or influencing parents. So that you need to say that effective recommendations include all the vaccines. You recommend HPV vaccine the same way that you recommend Tdap and meningococcal, and that you do it at the same time. As I said, you recommend it today, the same day that you recommend Tdap and meningococcal vaccine. Next slide. So if a parent is hesitant, they also have now, they're using this to teach providers or talk with providers about this, and about, you know, asking the parent, ask and restate their concerns, acknowledge their concerns, and emphasize that it's a parent's decision. Be clear that you are concerned for the health of their child, not just public safety. Advise, allow time to discuss some pros and cons of the vaccine if parents are hesitant. And then be willing to discuss the parents' ideas, offer written resources. And then remember that the declining is not final. Any conversation can be revisited. So in the conversation, with at least one action that you and the parent can agree upon. So talking providers and working on frameworks for providers to use in order to discuss issues with vaccine hesitant parents. Next slide. And then being sure that everyone in the office understands the mission. And so there's a lot of videos. There's a video on the Shot by Shot website and Unprotected People website, www.immunize.org. And then I think Tamika will give a human story, but just actually understanding that human stories can also influence decision-making more than statistics. Next slide. So there's these portals that you can use for providers and just to educate yourself if you're interested. And this is on the CDC website. You can just Google "You Are the Key" and find slide sets and information sheets that you can use to educate yourself as a provider or just in the general population. Next slide. And there's a lot of continuing education that's also available. Next slide. And fact sheets for parents in both English and Spanish. These are all on the CDC website. Next slide. And these are also posters that you can download and use for any intervention research. Next slide. And one thing I just want to end the talk on is just kind of reminding us that here are the vaccine coverage rates in the US and actually in high income countries. And you see over time we're at roughly 88%. In females and 44% in, this is in high income countries, that also includes the US, but 44% in males. And next slide. And then low income countries, we see we're at, roughly 40% in low and middle income countries and 5% in boys. So we really do have to bridge this gap and try to increase vaccine uptake in low and middle income countries. We're doing some really exciting work that's just been funded by the NCI to work in Nigeria. I think there just needs a lot of effort country by country to try to figure out how to ensure access and increase coverage as we really aim to save lives. Next slide. So you see at the global impact of vaccination coverage, and you do see some reduction in during the pandemic period. And again, I think we need to really look more and more to try to increasing this vaccine coverage in low and middle income countries. The high income countries are much higher up here, of course. Next slide. So the tortoise and the hare. I think we are seeing a story of as we move forward. Next slides. We hope that the low and income countries are going to speed ahead, but you know, as the hare always reminded himself, don't brag about your lightning pace, for slow and steady won the race. Next slide.
Oh, I think this is the last
That's
slide.
it. Thank you very much for being so kind as to forward my slides. I thank you very much for the invitation and looking forward to hearing from Tamika.
Yeah. All right, Tamika, I'll turn it over to you.
Hello, everyone. So happy to be here. And thank you, Dr. Smith, for just such a wonderful presentation. I always get these little nuggets or reminders of what I need to use when I'm talking to parents and even personal friends who are on the fence. So that is really great. I'm just going to share my screen here. And so thank you for that beautiful introduction, Mary. I am just so happy to be here and celebrate not only being a survivor, but also share the human side of it. Because as we know, there's a lot of data, but these personal stories are what brings it together. So always very appreciative for including the patient perspective. I wear many hats, and one of the proudest hats that I wear is that of a cancer survivor. It's been 22 years, and it's been a very reflective time in my life. And I'm very thankful for each year that I have lived beyond cancer. And I made a vow when I survived it that I will do my part to make my survivorship count with every breath that I have left within my body. And so to understand where I am now in doing the work that I do, you have to know that this is me before cancer, and this is me now. So I've always been someone with a voice. I've always been someone with a microphone in my hand. It was never the goal to have cancer and talk about cancer, but as someone who has worked for many years as a television producer prior to being diagnosed with cancer, I'm glad that I found a way not only to weave in my professional background into my personal, so that personal and professional can work together. And so 25 years old when I was diagnosed with cervical cancer. And I remember thinking that this can't be it. I have so much more life to live, and that cancer is coming in and it's disrupting everything. And how can that be? And who gets cancer at 25? This was in 2001, where for me as a knowledgeable television producer working on many things, I wasn't aware of cervical cancer. I wasn't aware of the human papillomavirus. And if you ask my friends and family, I was always the go-to person that has this general knowledge of various things, but I didn't know anything about cervical cancer. So when it came into my life, it was really devastating, and I didn't know how to deal with it. Also, I look at where we are now when it comes to the stigma of HPV related cancers. And even though we're doing better than we were in 2001, but 2001 was a very isolating time for me. And I was ashamed. I didn't want to talk about it. I wanted to just live beyond it and put it behind me and never think about it again. But the truth of the matter is that it was such a journey, going through a radical hysterectomy at 25, followed by chemotherapy and radiation therapy. You know, it's Infertility Awareness Week. And so the loss of my fertility at age 25, and then secondary post-cancer issues, that I couldn't just put it behind me. You know, I think when you're going into something, you have, well, this is what I'm going to do, and it's going to work like this, but you don't know until you're on the journey and you're experiencing it. And cancer is filled with many twists and turns. And so I was just someone who was fed up, because how am I going to be this person, right? Can I just pick up the pieces of where I was prior to cancer and go back. This is me sitting in my cubicle at the newsroom that I worked in at the time. And you see me here being kind of cheeky and fun, but the truth of the matter is I felt awful. I was 26 years old by this time. I had had a birthday right after the week after my hysterectomy. I celebrated my 26th birthday, and I was still working part-time during treatment. So I would go to work and I would leave 3 days out the week to do radiation therapy. And one day I would go and have chemo and radiation. And my energy was completely zapped, but I was trying to put on my best face. I was literally putting on some makeup here. And everything on the outside I thought looked fine until a coworker said, "Are you really okay? Can you really do this?" And this is really what led to the Cervivor, Cervivor, and how I navigated it to make my survivorship count, because I felt like I had this experience, so I had to do something with it. And so what was that? I built what I didn't have. There were lots of websites, some that only showed silhouettes of people, but not a lot of websites that focused on cervical cancers. The ones that were, they looked like this. And I was like, well, I want to see someone. Where is someone who looks like me? Where is someone who's around the same age, single, navigating, being a professional after graduating college? Where can I find this? And I didn't find it. I found little pockets of support, little pockets of hope, but a lot of what I found during the time of 2001 was very negative, and it was very stigmatizing, and it didn't make me feel good. It didn't make me want to share my story. And I've never been that type of person to hide who I am. So it was really hard for me. And so when I look back on the organization Cervivor, which really is an extension of who I am, these are just a little bit of what we do. And probably what I'm most proud of is that, one, no one is alone. That was my biggest thing. I felt like I was the only one, and I didn't want anyone else to feel that way. So if you're watching this and you're a clinician, you're a fellow nonprofit, a community organizer, if you know of cervical cancer patients, I want you to let them know that, one, they are not alone, and they can become a part of our community, and we can train them through our Cervivor School to become patient advocates to support the work that you do, because you all are great at the data, and we make the data come alive. We have our Creating Connections, which is our versions of support groups. We have podcasts. We even have a Get Fit Survivor Slim Down. We want people to know there are also private groups built on some locations and different ethnicities. We have a Comfort and Care where we send out cards and bags of support, our website, just so many things. But we want people to know that they're not alone, and that there is a way for not only you to get support for your cervical cancer, but for you all, if you want to take your survivorship a step forward and make your survivorship count. And we're proud of the many people that we've partnered with. We have an award-winning YouTube channel, and it really is great to be able to share in that. And so who is Cervivor, this organization that I've been talking about? Cervivor is a global community of patient advocates who inspire and empower those affected by cervical cancer by educating and motivating them to use their voices for creating awareness and to end stigma, influence decision-making, and change. But ultimately, we want to end cervical cancer because now we know we can. I remember when the vaccine first came out a few years after I was diagnosed, and I was thinking, this is great. As someone who's lost both her parents to cancer, my dad from colon cancer, my mom from multiple myeloma, I think about what it means to eliminate a cancer. And so this is the first wave of winning the war on cancer. Unlike so many other cancers, as you've heard and you know, that we know the cause of cervical cancer. We have diagnostic tools that can detect that cause, and we have a vaccine that can prevent it. And so why is there so much slow uptake in the United States? I believe part of it is because of how this information has been rolled out, or the lack of it to the general public, but also because we need patient advocates to feel safe and secure to be able to share their stories. What works so well in so many other disease sites is that you have patients who back up the science. but patients have to feel safe. They have to feel secure in sharing their stories. And so we help do that, bridging that gap between our nonprofit partners, our government partners, our industry partners, and we're building a community where people can actually do that. And so you are never alone. These are various members at various events. The pandemic happened, and while the pandemic was very hard for a lot of people, it was hard for our community. But the one thing that we had already gotten right is that we knew how to come together virtually. We know how to isolate, because when you're going through treatment, you have to isolate. And so I believe that while the world was tilted on this axis, in many ways, it brought us closer, and it brought us people like Jody, who was unfortunately someone based in North Dakota. And Jody came in, and I look at her face. This is one of my favorite photos of her, because I remember when she posted it, and my heart just tugged at one, that I love that people resonate with this word survivor, that they wear it as a badge of honor, that they want to be a survivor, and they believe it and they get it. And so for Jody, we were a beacon of light for her. When she felt alone, when she felt like there was nothing else for her, that we were there for her. And I was excited that we got to cross off another state where we had representation. And the sad thing about it is that Jody, during her short time with the organization, she did so much, but I know she wanted to do so much more. In January of 2020, we gave her the Brittany Wagner Social Media Advocacy Award. Brittany Wagner was a woman who never got a chance to attend Survivor School, unfortunately, because she succumbed to her illness and she was always too sick to come, but she was always on social media using #Survivor. Jody was another beacon of light like that. She found us through the hashtag, she kept using it, and she really was showing up and showing the experience and what it was, one, like to be a survivor in North Dakota, how she had to travel for treatment, how she traveled for her groceries, and what that was like for her and her 2 young children, her husband, their lives, and navigating this cervical cancer diagnosis. Jody passed away on Christmas Day. One of my last messages with Jody was, she just got this heavy news. Everything grew and it spread to her lungs and liver. She's starting yet again another chemo in the morning. But the words that I feel when I think of Jody are this: I've got babies to love on and a man to love for much longer. And it breaks my heart to this day because Jody died. And the reality is that people die of cervical cancer. And I think if more parents understood and didn't just think that it was an easy cancer that you could just have cells removed or get a hysterectomy, but sadly, people die of cervical cancer, and we need to make sure that everyone knows. And so Jody's story will continue to be shared. Her friends and family raised $1,800 for our organization, and they created these special shirts. And while I wish Jody was still here, we'll continue to share our story. And I hope all of you in North Dakota will join us when you do your presentations, when you do this work. Not only share Jody's story, but remember her and her family and our survivor community. When you do this work, we're happy to share. You can reach out to us at info@cervivor.org, and someone can put that in the chat. But I want people to know that this is a young woman, a young mom who should still be here. But HPV, cervical cancer, took her away from us. And while Jody wouldn't want me to just end there, I want to end with, at 25, I lost my fertility. And probably the hardest part of my journey with cervical cancer was that, and I was thankful that I didn't lose my life, but through the kindness of a stranger, a fellow survivor who came into our organization during the pandemic, she and her husband, who you see there, had twin boys via a surrogate. They had unused embryos, and they donated those embryos to my husband and I. And because of that, we now have a son, Chayton Lennox. known as our Cervivor baby. That name was given to him by Morgan, our community liaison, and it just stuck, and it's so appropriate. But I wish that Jody would have been able to meet my son and have my son play with her sons. But this is why we all do this work. We continue to do this work. And today, I'm doing this for Jody. I'm holding her close, and I want to make sure that you know that everything you do, there's a patient, there's a person behind all the work that you do. And I thank you for it. And while it didn't move fast enough to save Jody, we have an opportunity to save so many lives in the future. Thank you all. And this is some contact info. You can contact the organization, you can contact me. There are a lot there, so we're happy to support your work in any way.
All right. Thank you so much for sharing that touching presentation, Tamika, and the wonderful presentation, Dr. Smith. I am going to get my screen shared again. And before we move into questions, I just wanted to add that there is an evaluation survey that you can scan on this slide and take as we move into questions. We will also send out the link in the follow-up email after the presentation. So the first question that came in are, what are the most common misconceptions about the HPV vaccine, and what do people say to people who hold them?
Yeah, I think the answer to that question is very highly dependent on region and country and location. I will say that globally, there has been several studies done on just the idea that if you vaccinate, if they're general, specifically focused on girls only, that you're vaccinating to reduce fertility. That's, I think, a very, very large one. I think the gender neutral vaccination programs, I think, may help that if you're proposing to vaccinate both young boys and girls. I think, again, that there are behavioral experts who focus on how to address these kinds of rumors or misinformation. I think taking the time to understand the origins of a given rumor or misinformation, I think, is really important. I think on one of the slides I said just taking the time to listen to the reasons why people think about a certain misinformation about vaccine, I think, is really helpful, and talking it through with them and sharing data and listening, and I think is really helpful. Again, I think there are a number of different potential misconceptions, and again, they really do differ by geographical location and site.
Mm-hmm. Thank you.
I'm not sure if Tamika wants to add anything to that.
I had to get my little work buddy. But I do think a lot of social media is such a place where people get a lot of information from, and we're sharing it fast and quick. And so it really is about great sources where you're looking. And because so many people are driving information that is unsourced, we have to also be those great advocates and continue to put that information out there.
Awesome, thank you for that. There's two other questions, and they're a little bit similar, and you did have a really good slide, Dr. Smith, on this, but just in case there's anything to elaborate, here's the first one. Do you have any tips that healthcare providers can use to help persuade parents to vaccinate against HPV earlier? And then advice on vaccinating adults and words to use for shared clinical decision making.
Okay, so the first one was in relation to some of the messaging around vaccinating girls earlier. I think
Mhm.
that there's actually been a real shift from how we originally we promoted vaccine in the US. And I think in Europe, for example, they really focused on the adolescent, you know, up to age 14 or up to age 15, and they didn't actually allow provision in most countries above that age. Whereas the US, we had it was basically a very inconsistent message, which is like, we really want you to vaccinate early, but you're allowed to vaccinate up to age 26 for catch up. And there were some of us in expert panels were saying, I was saying very loudly, I don't want catch up. I want ketchup on my hamburgers, but not in my vaccination program. And in that you just really want to focus in on the trying to really increase coverage in the younger age group. I think so now they're doing a lot of efforts, as I said, about trying to really promote the younger age vaccination. I think there's other discussions now about how can we get vaccination down to even younger age groups. And there's a lot of work around reminders. Like I know that Nadia Viole, who's actually a colleague of mine at UNC, is really interested in this issue of trying to really start reminders for HPV vaccination even earlier, because there's discretionary use. You can actually provide vaccines down to age 9 and trying to have the reminders in the medical systems to remind patients that, hey, you each really thinking about HPV vaccination now. And the earlier that you thinking about it, if you start thinking and talking about it at age 9, maybe you can actually get young adolescents vaccinated at age 10, rather than trying to think about it at age 11 and try to vaccinate at age 12 or 13 or 14. So just trying to have the discussions earlier around the vaccine, I think, is also helpful. And actually just educating parents that, when you vaccinate earlier, you have higher antibody titers that are induced, and that you're kind of separating the vaccine in a lot of ways from sexual behavior, that if you're vaccinating early, it's not really linking the vaccine to sexual behavior, but ensuring that you're getting vaccine before exposure. That makes sense.
Mhm.
And also making sure that the language, as we're educating adults, that the stigmatizing language that's already out there. There are many websites, brochures, things that have multiple sexual partners and different things like that, when the reality is you could have one sexual partner and get HPV and it spread and turn into an HPV related cancer. And so I think we, moving forward as a society, have to be really, really, really careful about those things as well, because that trickles down to how parents feel about their own lives and what they're thinking of their innocent children. And we have to be careful with that.
Wonderful, thank you. And then the last one was advice on vaccinating adults and words to use for shared clinical decision making.
So when you mean vaccinating adults, you mean educating parents about vaccinating their children or vaccinating themselves?
That's how I'm interpreting it, is vaccinating children, talking to the adults, and words to use for a shared clinical decision.
Yeah, I mean, I think that, and in my presentation, I think I hopefully covered that pretty well about just making HPV vaccine, normalizing HPV vaccination, that it's just part of the regular adolescent platform. You need 3 vaccines today. They're meningococcal, HPV, and Tdap, and let's get your vaccines today, rather than making it a special one that requires a lot more discussion. And of course, if there's discussion required, and if parent expresses hesitancy about HPV vaccination, then having the tools to take the time to talk through it and listen. I think other things that are really important in the decision making is, as I said, listening and acknowledging and the framework that I had gone through earlier.
Wonderful. All right, I didn't see any other questions. And so we will move into our closing. Thank you so much, Dr. Smith and Tamika, for taking the time and being here today. And to all who could attend this presentation, to stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, and Twitter, and Foundation for Healthy North Dakota on LinkedIn. And also to join the coalition, visit the link to stay aware of future webinars and updates on the foundation. And lastly, here's another chance to scan the QR code and take the evaluation survey before it's mailed out. We would also love to hear from you if you have a story to share. We value the stories of the community members, and So if you know someone or have a story to share on how a disease impacted your life, you can contact me. My email is on this slide, and leave a brief description within the evaluation survey. There is a designated question for this, and we will follow up with you. So thank you again, everyone, for joining, and have a great rest of your day.
Tamika, so happy for you. Congratulations.
Thank you. Thank you. Thank you.
So
Thank you
cute.
so much.
Bye, everyone.
Bye-bye.